So this will be fun, I hope. I don't know. When Tracy told me, I looked at the Selective and realized I didn't have sort of an unfiltered opportunity to actually talk to all of you for an extended period of time over the course of the Selective. So I thrust myself into this this talk, which is, I think, hopefully will be a natural segue from what Faisal shared with you guys last week, which was terrific, I thought. And the other disclosure I have is that I'm used to teaching a seminar with students over the course of a semester, and usually I have 20 plus hours to work with students and to talk to them about a lot of different aspects of global health work. And so the challenge for me today was to try to cram, and I haven't crammed 20 hours worth of material into 90 minutes, or what we have now, that's maybe 70 minutes. But there's a lot I'd like to cover. We'll just see how far we get. And I apologize because this is the first time I'm going to try to fit a lot of different strands into the time we have together. It's also an opportunity for, I hope, you guys to just think on your own based on what we talked about today, and then hopefully that is an invitation for you guys to reach out to me, either in groups or one-on-one, anytime if you want to dive deeper into the things that I'm raising today. But really, there's just absolutely no way 70 or 80 minutes I can share with you all the things I'd like to share with you, having worked in this space for over 2 decades. And so today's title officially on your Selective said what? It's the Architecture of Global Health. I changed it to reflect what I'd like to talk about, and part of what I will talk about is the architecture of global health, but hopefully from a perspective that isn't super dry or boring, which is always the risk when you get to talk about the architecture of global health. The name of it sounds super boring. You guys all see the cartoon I have up there. I'm not making a political statement. I actually think that that's one of my truths. Can you read it, Lee? The lifeguard. There are a bunch of dead people in the water. What does the lifeguard do? It says, libertarians make bad lifeguards. You get the joke? Lee, you're still looking puzzled. Yeah. I thought this was an obvious joke. Apparently not. We're not going to have a political discussion about what it means to be a libertarian. For those of you who know, you can share with those of you. All right. So here's a quote that I always, Lee's seen this in Brazil with me at the end of the talk. Faisal set us up last week, and I think he did, a fabulous job of not being overly, I think, harsh or critical. He was just describing the reality of how what we now call global health has evolved over the course of a couple centuries. What I will share with you a little bit today is that in the last decade, less than a decade, there's been a fair amount of, I think, appropriate and quite damning criticism of global health as a set of practices in the last, in the way it's actually manifesting itself in practice. And I don't think it's, like I said, inaccurate in some ways. And I also think, much more importantly, as somebody who's invested in this and who cares about it and who wants to encourage you to think about how you may choose to engage or not, I don't want to shy away from what is hard and challenging about practicing in this space. And so that's why I think being brutally honest is actually really important. So I always like to tell people I'm a cautious, optimistic cheerleader for global health, but I am cautious and I'm measured. And so what you won't get from me is sort of just rah, 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 rah. It's all, wine and roses and romantic and glamorous, because it isn't. And we need to look at ourselves seriously and think about this when we're talking about it. So our objectives for today start off by reflecting on the place and space for idealism in the practice of global health. We will do a little bit of, maybe a lot, of a dive into the multidimensional architecture of how global health currently functions. And hopefully not just today, but throughout the selective, we will continue to cultivate our capacity for critical introspection. Sound okay? Right. The first question for you guys. What are you primarily being trained to become experts at when you enter medical school? Anybody want to offer an answer, suggestion? Please, Johnny.
Practice and to think like physicians.
Practice and to think like physicians. Anybody want to add or embellish? Or is that good enough for everybody? Yeah, come on. Western medicine. Okay. Yeah, good addition. Anybody else? Yeah, please, sir. What's your name? Just so I won't remember, but I remember you from last week. You're sitting in the back again.
I would say primarily science of medicine and secondarily the heart.
Cool, very good. Yeah, the science of medicine, objective, and then art, subjective. But primarily science, right? I'm sorry, what was your name again? Sedhart? I'm gonna keep working on it. No, you shouldn't apologize. I will practice it. Okay, next question. What aren't you being trained to be an expert at? I mean, there are a lot of things, but you're not trained to becoming a lawyer, right? Please,
How
what's
to
your
deal
name?
with, Esther,
Esther, great.
how to deal with insurance.
Wonderful. Not what I expected, but that's awesome. Yes. Not to deal with insurance. After 35 years, I still don't know how to do it. I'm not sure Lee does either. Anybody else? Yeah, what's your name?
Sabrina,
Sabrina, great.
how to enact a structural change in the healthcare system?
Big, yeah. How to enact structural change in the healthcare system. Please, your name?
Jennifer,
Okay,
I was gonna say that we're not being trained to be policy experts.
good, yeah. Not being trained to be policy experts. One more or no more? Keep moving. Keep moving. All right. This is actually a UCLA slide. I Googled social determinants of health. This came up really quickly and I was super excited. So why do I have this up here? Is the arrow or, well, forget it. Let me just point. So, human being, science, art of medicine, expert doctors, it's 20%, right? Of what goes, I mean, this is just, I don't know where this percentage came from. I think it's probably right. Maybe it's 10%. This is what you're being trained to focus on as physicians. Science, art of medicine, how to be really, really good clinicians. That's the majority of what you're going to get in medical school and in residency training. It's not all you can get, but that's certainly the vast majority and emphasis. And that's a good thing. You're being trained to be expert technicians, clinicians, physicians. What are you not being? Some of you said you're not being trained to you may be trained to think about how to encourage healthy behaviors, but you're not being trained how to be experts at changing and encouraging people to be healthy behaviors, certainly not in medical school. Come on in. And if you guys run out of food, you can take mine. You're not being trained to think about the physical environment and how to change and fix the physical environment that leads to a lot of healthcare problems. You're certainly not being trained to think about and being an expert on the multiple socioeconomic factors that impact health. Is that fair? Do you guys feel comfortable with that characterization? Does that sound right? You signed up to go to medical school, you didn't sign up to go to public health school, you didn't sign, maybe you'll get an MPH, you didn't sign up to become, a housing expert, you're not getting a PhD in environmental studies. Makes sense, right? Okay, second truth, besides libertarians being bad lifeguards. Being a doctor does not make us experts at global health. Okay? Maybe that sounds obvious, but it's actually a really, really, really funny phenomenon in our profession. Faisal's smiling because he knows this. When you get out of here, when you get out into the world, it's so easy because there's so many opportunities for you to engage that you just think by virtue of your training, I'm an expert at global health. The reality is that nobody is. Please, yeah, find a place to sit, chill out, enjoy your food. Why did I put this slide up here? It's a very busy slide. It's a lot like the other one, except it shows you that it's about maternal mortality, right? This is where you interface as an obstetrician or an anesthesiologist or a surgeon or a primary healthcare provider or a family practice doctor. You see a patient coming in, she has an obstetric emergency, and either the system works to help you save her life or it doesn't and she dies. That's what you're being trained to interface in, right here. What you're not being trained to think about are all the massive things that cause the problem in the first place, right? Lack of housing, transportation, lack of a blood supply if she needs an emergency blood transfusion because she's hemorrhaging, all those things, right? We can go on and on and on. The most significant health challenges in global health, as I've told you, are about the health system, and they're about infrastructure. They're not about you being able to practice your craft like you're being trained to do. Does that make sense? Okay. On the other hand, here's the good news. Being a doctor is a stunning privilege for us. And it's a stunning privilege because we get to bear witness to what is sometimes really painful things to watch and to witness, suffering, human suffering caused by illness, caused by calamity, caused by whatever. And we have an opportunity to try to fix it, right, based on the skills that we have. This is a picture from Sierra Leone during the Ebola crisis. Okay, anybody know who this is? Paul Farmer. Paul Farmer. One of my mentors. Paul's rest in peace. Paul would be happy that I'm here spreading the good word, as he would like to say. But he would also want me to, there's a lot I could share. We could have a whole class series on him and his work. But he would want me to remind you guys that from, after he graduated from internal medicine to up until really 2000, nobody knew who Paul Farmer was. And that was a good 15 years of this practice. So he was in Boston with the Brigham, practicing internal medicine. And he was just very, very devoted. And I'll give you a one-liner why. He is a deeply, profoundly Catholic person. So he did a very good job of just not advertising that or announcing that in all of his work, but his drive to care for people wherever they were and anywhere came from his profound faith. And as he got older, he shied away from, he was less shy about sort of acknowledging that, okay? But my point is that for 15 years, nobody knew who Paul Farmer was other than a few people at Harvard and a few people at the Brigham who thought he was this esoteric, eccentric, super, devout and committed human being who just cared about a particular place in a particular country that has, a very long and problematic history. Country of Haiti. Okay? Paul lived famously, he would basically be at the hospital for 20 hours a day, and he would sleep in the basement of a church in Boston that is now quite famous for other reasons, but he didn't have a place to stay, and that was just the way he was constructed. His brain and his life was constructed in the way that he just cared about being a doctor all the time for anybody that wanted to do it. And he would joke with me, he's like, Sad, up until, the middle of the 2000s, when somebody happened to write a book called Mountains Beyond Mountains. Anybody heard Tracy Kidder, who's an author? He wrote this book. I recommend it. He was just busy toiling away with his little group of friends who were sort of committed and sneaking drugs and equipment on airplanes to go to Haiti to work. And he wrote some books that nobody had ever heard of. An anthropologist in addition to being a physician, he got his PhD in medical anthropology. So, I mean, literally, nobody read these books, being honest. And he was like, well, I just wrote books about what I bore witness to as an anthropologist, right? And how appalled I was that the world just refused to like do anything. And only again because of serendipity, honestly, Tracy Kidder writing a book, did things suddenly change dramatically. Partners in Health, which he co-founded with Ophelia Dahl and Jim Kim, was sounds like a lot of money, but it really isn't in the picture. $5 to $10 million NGO in the late 90s and 2000s, early 2000s. That's what it is now. 250 million dollars. It's a lot, right? So when I met Paul, it was still very low stakes, relatively speaking. And you know, for me, there's a lot of lessons to draw this. The one I will just share with you is that bearing witness as a physician to human suffering is a universally powerful thing to share with other people. And if there's nothing else that you can take from this selective, it's just remembering that. Sharing your narratives of human suffering is a hell of a lot more powerful than 50, if not 90% of the other things that we ask you guys to do, particularly in academics. So don't be afraid to embrace that when you see it and you want to talk about it or write about it or share it. That make sense? Okay, we'll keep going. Ideals in global. Well, this is the first opportunity for people to earn a coffee with me. We've got 10 opportunities if you guess right. First quote, famous quote. If it's in our power to prevent something bad from happening without thereby sacrificing anything of comparable moral importance, then we ought morally to do it. I'm not going to ask you if you agree or disagree. I'm going to ask you if anybody knows who said this, who wrote this. For a cup of coffee. You can guess wrong, and you just go pick coffee. Faisal doesn't know. I know Lee doesn't, but he didn't study philosophy. Oh, awesome.
Your guess, is it Kim Jong?
It is not. Good guess, though. I appreciate you trying. Any others? Oh, here we go. Oh, I haven't heard from you, Timothy.
Oh,
And you can't Google it. If somebody's cheating, I'm really disappointed.
I'm not sure if I know like the person who said it, but is it one of the 4 principles of bioethics? No.
It is absolutely not. But I love that you thought that. I'm gonna go and remind me your name again.
Nazo.
Naza.
Nazo.
Naza.
Mhm.
Great.
This is also a pure guess.
That's
but
okay.
Arthur Kleinman?
No. All right, Johnny. Not John Locke. You're closer-ish, kind of. Last guess. One more. Anybody else? All right, first cup of coffee's out. Oh my gosh.
Paul Farmer.
Not
That was good.
Anybody taking a philosophy class?
Emmanuel Kant.
Not Emmanuel Kant, but you're not gonna guess? What was that? Oh, nobody's, my dad, it's a philosopher, very famous philosopher, still alive, very, guy, not John Locke. Like, I love that you guys are going deep, but like, contemporary, he is a super influential guy in a particular movement that first got a ton of like positive press, and more recently because of some funny business going on in the crypto market, no longer so positive. Oh. No, he's the crypto guy. He's not a philosopher, although he thinks he's a philosopher. Sorry? Yes, effective altruism, right? What?
Peter something.
We got the first name. We're never going to get through my slides. But
Singer?
Peter Singer. I took a lot of effort. We're not gonna, you didn't get a cup of coffee.
Like half.
Half a cup, perfect, all right. Half a cup. What's that?
I want the other.
You want? All right. Well, this is good, more. We're literally gonna get through half of this. All right. Anybody got this one? From each according to his ability, to each according to his need. They're just your all awesome science people. Ah! I love it. What, say it out loud? Karl Marx. That's okay. This isn't about agreeing or disagreeing. I'm just, did you cheat? Computer's up. That's fine.
Don't audit me.
Okay. Karl Marx. Everybody know who Karl Marx is? Or the name? What's that? There we go. Karl Marx.
Terrible book.
Terrible book. Medicine should be viewed as social justice work in a world that is so sick and so riven by inequities. You get a cup of coffee, by the way, if you'd like. You don't have to. If you'd rather you have it with somebody else, please leave him. He's got a good coffee in his office. We talked about him. No coffee for this one. Paul Farmer. All right. Poverty is the worst form of violence. Take this in the best sort of way. My South Asian colleagues, come on.
Gandhi.
Thank you, Gandhi. Could have said my South African colleagues because he was in South Africa too. All right, gosh, I don't think anybody got it. We're gonna half a cup of coffee too. What's your name up there?
Oh, hobby.
Avi, and I forget your name. Yeah, you get a full cup. Don't worry, there's 6 more opportunities. You guys didn't, I gave you a huge hint, like, oh, you all get a 4th. Shot of espresso. All right. Anybody know who Jonathan Haidt is? Sociologist, NYU. This is good, I'm talking to you guys. Jonathan Haidt has a opinion article in the New York Times this morning. He among others has developed. He's done some really interesting empirical work, and he's not interested in theory, moral theory, but he is interested in describing human moral psychology, what is sort of universal in our psychological experience. And so he makes the argument based on surveys of literally tens of thousands of people all over the world that there are. He has 5, some other people have added the 6th, I'll tell you what the 6th is. Sort of hardwired components to most human beings' moral psychological framework. They are caring or harm, avoiding harm, fairness, loyalty, authority, sanctity. Liberty wasn't in his initial formulation, it's sort of in it. So I share this with you because I think there's actually probably a reasonable basis for thinking that most human beings' brains have this little bit of hardwiring sort of set up, and how any one of these particular characteristics or predispositions ultimately manifest, and the priority depends on where you live, what your circumstances are, the stresses you face, the environment you're brought up in, your parents, X, Y, and Z. But we all have these characteristics. What theorists do is try to say this is the order that we should have them if we're thinking rationally about. Okay, so there's a difference between the fact that they exist and whether or not we should prioritize them in a certain way. That's a contest of ideas and arguments. Just to remind you guys, libertarians with that. All right. This is the time I want you guys just to take a minute on yourselves individually. Close your eyes, find your meditative space. That's what I do. This is meant to be very much an honor, the idea of meditation and mindfulness. I want you to think about how you think about your own sort of moral commitments. Okay? Take a minute. All right, thanks. I'm not gonna talk about it. I just want you to hold that inside of you, okay? I might come back up later. Now we're gonna get to some boring topics. The other thing that Tracy scolded me, I'm like, what? I can't give the students assigned reading? She's like, they won't do it. They won't do it. Come on. So, since you won't do it, I'm gonna read for you some of the articles I would have. Yeah, right? I think we can get away with it. So Alan Brandt is another mentor of mine. He's a brilliant, terrific medical historian who's been at Harvard, now retired for over 40 years. If you have the time to read a 700-page tome about cigarettes and the history of the cigarette industry in our country, it's called The Cigarette Century. I highly recommend it. In the summer break, 5 years from now. Brilliant. He wrote this article in 2013. It's in the New England Journal called How AIDS Invented Global Health. You know, Faisal hinted towards this, intimated about this last time. I just want to share with you his optimistic spin in 2013. It draws together global health, scientists, clinicians, public health officials, researchers, and patients while relying on new sources of funding, expertise, and advocacy. This new formulation is distinct, first of all, in that it recognizes the essential supranational character of problems of disease and their amelioration, and the fact that no individual country can adequately address diseases in the face of the movement of people, trade, microbes, and risks. Second, it focuses on deeper knowledge, the burden of disease to identify key health disparities and develop strategies for their reduction. Third, it recognizes that people affected by disease have a crucial role in the discovery and advocacy of new modes of treatment and prevention and their equitable access. Finally, it is based on ethical and moral values that recognize that equity and rights are central to the larger goals of preventing and treating diseases worldwide. It's like a 5-minute read if you guys want to do reference. Same year, same journal, our future chancellor, Julio Frank, Dr. Julio Frank, published this article with Suri Moon. Julio was the dean of the School of Public Health at Harvard back then. He had a more, I would say, realistic or sobering spin on how global health was shaping up in those first few years since it had become an entity. It's a little bit more to read here. But he titled their essay, Governance Challenges in Global Health. Global governance is distinct from national governance in one critical respect. There's no government at the global level. Populations are organized into sovereign nation states, but there is no hierarchical political authority or world government that has jurisdiction over the nation states. The WHO, which lots of people think, well, isn't that that's where we should go, right? That's the entity. WHO is now governed by 194 member states and is charged with organizing international responses to shared health challenges. However, there is widespread consensus that the current institutional architecture, now more than 60 years old, is unable to respond effectively to contemporary global health threats. Today, the WHO stands on a crowded stage. Once seen as the sole authority on global health, the WHO is now surrounded by many diverse actors. We don't have time, but we could spend a whole, again, semester talking about not only the history of the WHO, but how it functions and operates. It's a complicated story. I'm not going to read this just for the interest of time, but Julio and Suri identified 3 major governance challenges and characterized them as the sovereignty challenge, which just has to, again, to do with the fact that every country is its own sovereign nation and can decide what it wants to do when it comes to healthcare for its people. There's no way to get around that. The second is the sectoral challenge. And what he's basically suggesting here is that even though global health implies and implicates all sorts of different disciplines and sectors, it is just very hard and ill-equipped to bring different sectors together, whether it's the environment, whether it's the health sector, whether it's industry, whatever, together to sort of come up with consensus solutions. And the last one is the accountability challenge. And this is one that is going to be a recurrent theme, is that there's really no accountability in global health. Because again, there's no governance, there's no structure to make people do what you want them to do and have the force of law to make you do what you want. Julio and Suri had a slide that attached it, and this was, I think, generous in 2013 suggestion of what the global health system looks like. There are philanthropies, there are civil society organizations, what we call NGOs. There's the WHO, there are countries, there are multilateral organizations like Gavi and the Global Fund, X, Y, and Z. There are academic institutions like UCLA and Harvard. There are bilateral cooperative agencies. The media, there's the private sector. You can see it's a lot of different actors. So my question is it a system? Or as some people like to call it, open system anarchy, open source anarchy. So a couple of anthropologists from Princeton, same year, 2013, had this to say about global health. Multiple approaches, moral principles, methodological techniques, and epistemologies cohabit within the broad framework of global health. Many would agree that global health is more a bunch of problems than a discipline. Arthur Kleinman, somebody said that name, that was his quote. While the field still debates fundamental questions of self-definition and values, as Faisal showed you, it has nonetheless become a significant political, economic, technological, and social nexus for a wide variety of actors and interests that engender projects that are complex, diverse, temporally unstable, contingent, and often contested or resisted at different social scales. Not the rosy picture you guys were hoping for in taking Selective on global health, but accurate. So let me talk about some of those different priorities and different agendas again, just sort of in a cursory way. This is from an article in 2020. I actually reviewed some colleagues in Germany. Security as a leading priority. The value is to protect citizens' health with a focus on economic and national security, right? Sovereign nation. Cooperation with other state actors on emergency preparedness within nations, on the prevention of outbreaks outside set national borders. That's the emphasis. We want to do global health with an emphasis on security. Entrepreneurial. Leading value is the promotion of innovation, quote unquote disruption, encouraging public-private partnerships, market-based funding mechanisms, focusing on new technologies and digitalization. Humanitarian. Leading value is alleviating immediate suffering and saving lives based on charity and philanthropy, responding to large-scale emergencies, disasters, or crises in cooperation with international non-state actors, humanitarian NGOs. Technical academic, leading value is generating evidence, right, through science to improve health, using your technical expertise to generate, hopefully, sound policy focusing on data generation, outcomes measurement, research-informed program implementation at various levels of scale. Social justice. Leading value is moral solidarity and human rights, direct horizontal cooperation with local partners, stakeholders, service delivery, political activism. What I want you guys to appreciate is that it's not that these things have a hierarchy. They exist right now in tension with one another, right? So Timothy could be a social justice warrior. And when he says, I'm doing global health, he means I'm going to be working on horizontal programs, working on health equity on the ground, working in advocacy, working on delivering healthcare in a way that, tries to manifest that. Johnny could be an entrepreneur and be like, you know what, I want to create the next cool tech device that's going to save 10,000 lives in the Gambia. And he's going to find a way to do that because people want him to do that, right? Esther could be really into national security. Be like, you know what, I just don't want Ebola to come up to the United States. So I'm going to work in a way that, makes sure that our policies and systems work so that Ebola never comes up or door, right? And there's nobody that can say definitively or authoritatively that any one of these three isn't doing global health, right? Because all of those modes of engagement are validated right now. Yeah?
explore the tension between humanitarianism and social justice movement?
Yeah, so there's overlap. And I'm glad you brought that up. There's overlap between all of these, right? So you can have commitments in different spaces, but your primary thrust may be one way or the other. The distinction that is often drawn between humanitarian, and Timothy and I actually talked about this last week, and social justice is humanitarian is generally bracketed as an intervention in the moment of a crisis. Tsunami hits, there's a war, there's an earthquake, you name the crisis, and humanitarianism goes in and tries to manage the healthcare crisis that's happening, regardless of what else is going on in the moment. And then it steps out and doesn't do anything to, keep working on the background conditions. Social justice is, we've got a fundamental problem the way health system is organized. We need to work on this, for the next 100 years, and we're going to keep working at it regardless of whether there's a crisis. There's a sort of a crisis that's always been going on, right? And we're kind of trying to deal with that. That has to do with sort of justice, and has to do with solidarity, and has to do with human rights. Does that make sense? Yeah. Any other questions? Okay. More sobering truths. Global health work as a field of activity is a social institution, right? We can't avoid that. Integrated into and influenced by the structure of other social institutions in particular contexts. Those who work on global health issues tend to view the topic through a lens that has been molded by their social experience. Okay, so what do we start talking about? What are you guys trained to become? Clinicians. So you're naturally going to be mostly exposed to what a clinician does if they want to participate in global health, and that is practice your craft, right? Here's the second part of this quote from a great book that I recommend. I'm Solomon Benatar, who's up in Toronto. He's also retired. Global Health and Global Health Ethics. Global health work is thus a human activity that takes time and money. So is guided by and directed by those forces that have control over money and time. The dominant social and economic forces in society determine to a large extent what global health is about and how it is used. That is the most accurate description of global health that I've ever come across. Surprise? Not surprise, right? You're all realists, right? Even if you have ideals. Okay, let's talk about money. These slides will be quick. Top 10 donor governments to global health in 2022. This is all from the Kaiser Family Foundation. Great source of data if you want to find that. Trajectory of global health funding from the United States itself over the last decade and a half. A lot of money. It's in billions. Okay. 2021 was a blip because of the U.S. pays the most money into multilateral global funds. The Global Fund gets the vast majority of it. You can see Gavi gets some, TB Global Drug Facility, WHO, and these are in millions of dollars. What do we spend our global health funding on? This shows you over time. This shows you on what? What's the big winner? HIV/AIDS, going away, has been, continues to be. Right? You can see the other things there: maternal child health care, global health security, malaria, NTDs, nutrition. Any comments, concerns, surprises? No? Where does the money go? Mostly Africa. Which countries in Africa? Nigeria, Tanzania, Mozambique, South Africa, Uganda, Zambia, Kenya, Malawi, Zimbabwe, Ethiopia. Those are all in billions, $500 million down to 200. It's not a trivial amount of money. And that's in 1 year. Who decides where this money goes? All right, talking about the architecture, right? More in global health. So, USAID, dive into that a little bit. State Department. State Department is primarily responsible for PEPFAR, which is the primary funder for HIV/AIDS work in the world. HHS, Health and Human Services. CDC, NIH, FDA, all fall under that. Our global health engagement, meaning our money, flows through two main structures. The foreign assistance structure, which is primarily USAID, and the public health structure. The best example of that is the CDC. Okay, second opportunity to get coffee. Anybody know who that is? There's going to be at least one on here that I know. I hope you know. Not the director of the WHO, but I appreciate the guess. Thank you. Head of USAID, Samantha Power. Is at Harvard for a really long time. Out of position. Somebody's got to know who this is. Ah, okay, you all get coffee. Anthony Blinken, and he is what? Secretary of State. Right. Might know this. So he's an LA guy, former LA guy. Gosh. It's okay. Head of HHS, Javier Becerra. Okay. All right. Definitely not gonna know who this is. You get 2 cups of coffee. John Kangasong, PhD, is the head of PEPFAR. It's the head of Africa CDC before that. Anybody know who that is? You guys might know who this is. Famous writer, surgeon, Atul Gawande. On coffee. Atul is no longer at Harvard. He is basically he reports to Samantha Power and runs the global health part of USAID. Guys, you're definitely not going to do this. This is Lois Pace. She's the head of what's called the Office for Global Affairs. And so she reports to Javier in really conducting the HHS's component of and overseeing HHS's component of global. These people all are the big decision makers, right? About where those billions of dollars go. Not a bad job to have if you guys want to work. All right, we'll just burn through these quick. Department of State gets the most. USAID gets a huge chunk. Office of Global Affairs that Lois Pace runs, Centers for Disease Control, NIH, Food and Drug Administration, and HRSA all get a little bit. A bunch of other things, entities in the US government that get money. This is about the rough approximation of the money that they get. 52% to the Department of State, USAID about a third, NIH gets about 7%, CDC about 5%, DoD about 2%. So where does USAID's billions of dollars go? Let's just focus in on the 2 billion plus that goes to NGOs. We have to look at those. Just know that there's a long list of NGOs back in 2013 that were able to access billions of dollars that the US government gives to conduct programs, right, in the global health space. There'll be some names there that you would certainly be familiar with. Save the Children, International Rescue, Partners of Health. Here are the top earners of that US largesse. Anybody heard of Partnership for Supply Chain Management? Neither. A whopping almost $500 million in 2013 they got from the US government. To do what? Supply chain management. Remember what we talked about in the beginning? The problems of global health are not you being able to operate, right, on the patient who's dying in front of you. The problem is, do you have a blood supply? Do you have IVs? Do you have equipment, right, to be able to do what you're trained to do? So if we're not directing some of our money towards those NGOs, You can just stand there and unfortunately bear witness to somebody dying, right? So it's not that doesn't make any sense. It's just that you have to recognize that global health isn't just about the practice of medicine. In fact, it's very little about the practice of medicine. Go ahead. Not third party, they're audited internally by the USG. But if your bigger question is there some, are the dollars used super efficiently? The answer is it depends. Right, so Paul used to, you'll see that Partners in Health isn't on here. And Paul, I think somewhat, well, he was mean about it, and he was not a mean person. He used to describe many of these NGOs, let's just say not sympathetically, as beltway bandits. Because he wasn't sure that what they were doing was actually making any difference. And that's just his characterization. I'm not suggesting that you should agree with that characterization. Yeah, I want to be very clear. There is room for criticizing how this money is spent. And there certainly are some inefficiencies. Where does the money go to? Again, what we saw generally before, where does it go? Africa, primarily HIV/AIDS. Again, where does it go? You can see the countries. Okay. I was going to spend 5 minutes walking you through the website of USAID just to show you an example of how they market the good work that they're doing. I just recommend you do that on your own time. Okay, it's worth spending a few minutes just looking at the USAID. And a lot of it is terrific. Get me wrong. But it's interesting. It's quite varied. It runs all over the map. All right. Mindful moment. This time I want you to talk to your neighbors about what you just learned about a lot of money the US government supplies that really creates the architecture of global health that most of you, if you engage, are going to have to be a participant in some way or the other. And go back to what you were thinking about in terms of your own values. And see what you think about whether they align or not. And it's okay if they don't, it's okay if they do. Just want you to take a couple minutes to share with your friends about that. Make sense?
The motivation. The first meditation.
Sketchy, but yeah. But and also really long.
And the issue not being resolved in a different country.
I have some. I don't know if it's just like.
If this is the best thing for it. How you live with like the US government funding programs.
I don't know.
Like, they should like have money, like, you know, like.
Maybe that's.
Their values or their missions.
I was really thought like that. Not even just that, but even $50 billion. Like they're just playing it. Actually, right, yeah, you don't want to see it's too. Yeah, they must use their own. Can it make sense? You have to buy the stuff. Value. One more minute.
Also curious, like, I mean, talking about how like profit and like, and like,
That sounds like.
there is.
That's the reason why a lot of.
I mean, just based on like my activity on the internet, like I feel like there's definitely like needs to be But I think if money is like come out, is.
All right, let's wrap it up.
No way, they're not out yet.
You guys good to last for another 25 minutes? Up to 1:30? A lot of your honestly. I got an F for today's talk. All right, yeah, thanks, Ken. And plenty of bad reviews. Anybody want to share? Yeah, awesome.
We talked about how we felt like the stories and pictures and things you hear about global health settings in underdeveloped, under-resourced countries do not reflect that of receiving almost $500 million in resources. So where is that money actually going, and what does it look like once it reaches the recipient?
Great observation. Did you guys all hear that? No, Tracy did. Just the disconnect between the sum of money, massive sums of money, and what we see actually playing out on the ground. And how can $500 million not produce more? Right? Bang for the buck. Anybody else? One more set of observations? It's okay if not. Yeah?
Too much, but,
Okay.
we thought it was interesting, like, how like this money is also like towards the US's foreign policy arm, like, how much of this money is like being given out for purposes, or like, more realistically, like, how much of this is just for, like US influence?
Everybody hear that? I will say it again, right? So the US money, right, is tied to our foreign policy, right, agenda, our diplomacy agenda. So really excellent observation. And the fact is nobody would shy away from that. One of the reasons I wanted to show you the USAID Gov site is that it explicitly says that. There's nobody's hiding this. This is US taxpayer dollar money, ultimately, and it's meant to further US interests, whatever those may be, right? That's a political question. But there's no hiding that, right? And so part of that is foreign policy, right? Right? Part of that is securing our borders, right? Part of that is making the lives of Americans better, right? So you asked about specifically, like, how is this money being used? Is there an audit, right? So one of the reasons NGOs are the preferred mechanism, right? Really the only mechanism, well, not only, but one of the preferred mechanisms. What does it do for US business? If I'm the head of an NGO in the United States and I could access $10 million, that's economy in this country, correct? There are salaries, jobs being created, right? So the real question is how much of that money is going to support our employment and our jobs, and how much of it is going to actually save a life, right? Or do something elsewhere. And the answer is mixed. You cannot generalize here. The truth is that it's a mixed picture, and it depends on the NGO, and it depends on the contract they got. Does that make sense? Okay. Some places practice better, some places, well, let me say, some places, some NGOs practice more austerely in terms of their own, or leanly in terms of their internal sort of operations, and others are happy to have an office, in a nice part of LA versus, their homes. I'm not being facetious, I'm being honest, right? But both are accepted in the world of NGO land and money that comes from, right, elsewhere. Does that make sense? I may not agree with it, but that's the world we live in. That's the architecture of global health from micro level. You guys saw this, money and time, so. No comments editorial about this quote. It's from the Bill and Melinda Gates Foundation. Done a tremendous amount of good in the world, right? Can't think about global health without thinking about Bill and Melinda Gates, can we? They're impatient optimists working to reduce inequity. Putting a lot of money into global health. Red, orange, yellow. Again, only till 2013. Total amount of money in global health, US dollars, about a quarter of it comes from the Gates Foundation. Amazing. Billions of dollars that they're putting into this. This just says that. This year and moving forward, they're pledged to give at least $8 billion a year going forward to Global, every year. I'm just going to show you this amazing video of Bill Gates at Davos this year. You guys all know what Davos is. The very, I'm not going to bother to tell you what it is, but in any event, it's lifestyles of the rich and famous in Switzerland at a ski resort. Rich people in the world and political leaders of the world get to come and talk about how to save the world while they ski. I'd like to be invited. I've never been. Maybe if I keep doing this, I'll never get invited. Lee's probably been invited. Anyways, I'll share this slides with you. So I really, if you guys have 10 minutes, just watch the first 10 minutes of Bill Gates being interviewed. I'd love to have a chat with you about it over coffee. What do you think? So Gates, it's all good. I mean, $8 billion a year is, you guys know who SpongeBob is? I feel like I'm like so old, but SpongeBob is awesome. SquarePants? Nautical nonsense? You guys are laughing at me. He doesn't know who SpongeBob is. Are the Gates above criticism? They should be? They should not be. If you're a consequentialist, and I'm going back to philosophy 101, or a utilitarian, you would absolutely say they should not be. They should be above criticism. Because $8 billion versus some things that we don't like about them, we still take $8 billion every day. I'm not telling you that that's what you should think. I'm just saying that's the argument against being super critical of the Gates. The other reason to be not very critical of the Gates and why you don't hear too much about it in the mainstream media is what? An old saying. Oh, I love it. Say that out loud. Don't bite the hand that feeds you. If you criticize the Gates, then you're going to get that next check. 100%. Guaranteed. If you've been caught criticizing the Gates, don't even bother to apply. Anyways, this article from, where was it from? I can't remember. I'll send it to you. First guiding principle of the foundation is that it is, quote, driven by the interests and passions of the Gates family, noted an editorial in the Lancet. Is this kind of governance really good enough? As a private organization, the Gates Foundation is only accountable to its three main trustees, Bill, Melinda, and Warren Buffett. That troubles many critics. Another concern in the academic literature is that the Gates Foundation is focused on drugs, vaccines, and other technological solutions for global health problems. Many researchers, by contrast, would prefer a focus on the less exciting but crucial work of strengthening the health systems for countries. You all already know what Camp I is. An example of that, the Gates Foundation has received a lot of positive press for its role in financing the eradication of portfolio, undoubtedly a good thing. And yet, even that campaign had its critics. In her research, McGooey, this is a professor in the UK, found key stakeholders in some of the countries that were the focus of the campaign expressing the view that, quote, this was really a priority of wealthy nations and not necessarily developing ones, many of which were preoccupied with battling illnesses that created a far greater health burden in their nations, such as diarrheal diseases in India and polio. They were compelled to emphasize polio eradication against their will. Why? Money. Right? Somebody's handing you a check for $10 million. It's hard to say no. It'd be hard for me to say. Last thing, talked about accountability, audits. Same sociologist from the UK, who studied the foundation for over a decade. When I asked her about all the good work that the Gates has done, she said, quote, I honestly don't know, and that's the scary thing. It's very difficult to measure a private foundation's ethics. So again, the point of this isn't to say Gates is bad. I would never say that. I do want you guys to wear a critical thinking cap, right? Cultivate that willingness to not just blindly accept, right? That everything that is happening in this space is good, unqualified, unfiltered, right? Unchecked. There's room for you guys to participate as engaged consumers of what's going on and not be afraid to be critical. Just to bring it home in a very specific and meaningful way. Bill Gates put a lot of money into helping the COVID vaccine, right? Be created, be generated, making it accessible. What didn't he do? He specifically resisted the call by almost every nation and every, I would say, enlightened global health, leader, and said, no way I want to give up intellectual property rights in the vaccine, because people need to be able to make money. Otherwise, they're not going to make it. In the face of the COVID crisis, right? He said, I'm not going to, again, pass judgment. I just want you guys to think about it. In all of our conversation, who haven't we talked about? Say that. What's your name? Brenda? Yeah, I know what you said.
If people who have illness.
Agree? Have anything I've shown you shown a picture? I mean, have we talked about the voices of the patients that we are supposed to be there caring about, that we're there for? This is just, we've got so many slides and not enough time. Another example of entrepreneurship. I'm a neonatologist. I take care of sick babies, right? So I get consulted all the time from really well-meaning people who want to work in global health and do something, particularly around baby care. There's no question, hundreds of thousands, if not millions of babies are at risk for either falling sicker or dying because they're born small without a lot of body fat or a little premature, and they're prone to hypothermia, right? Hypothermia is being too cold, right? You get sick and you can die. So an MBA student at Harvard 10 years ago came to me and said, I want to do something about this. I took this really cool course with Paul Farmer and Jim Kim in the business school, and they want us to create new technology to try to fix the problems of the poor. And I'm going to make a baby wrap, low cost. That's Embrace there on the left. One of my dearest friends, literally 10 years later, medical director at the ICU in Boston Children's Hospital, said, she spent some time in Rwanda. I want to do something to help babies who are dying of hypothermia in Rwanda. I'm going to make something. I'm like, there's something called Embrace. She's like, I don't know. I want to do it myself. The dream warmer. I can give you countless examples of well-intentioned, thoughtful, genuinely good people who sit in seats like this who want to do something, right? And they come up with a great idea and they get a little seed funding from a venture capitalist or another company, and they say, go for it. Let's figure out a way to solve a particular problem from our vantage point. And then we won't worry about how to actually get it implemented in new countries. But it's a really cool idea, and it's also great marketing, right? Madhu Pai is a brilliant professor. Tracy knows him, and so does Faisal up in Canada. And you should just follow him and read all that he writes on his blog. But he and others have, again, written some criticism of the fetishness we have for tech solutions. I won't read all of this. Just recognize that, again, the idea that you and I sitting here, right, can construct a high-tech, low-cost solution, right, that is going to magically cure and fix a specific health problem in another country is fanciful thinking. Period. Okay? I'm not saying don't think about it. I'm saying if you're going to do that, you need to do certain things. And the first thing is go to the place, spend 6 months, understand what they think the problem is, right? And how they might solve it based on what they know is available, right? And what's meaningful. And then maybe start to work on a solution that actually might get money. That's the essence of this. All right, last couple slides. So what's happened in the last 5 years post-COVID? I mean, people were really shocked and pissed that COVID wasn't this moment that would transform global health as it's being practiced. In fact, we retreated right to vaccine colonialism, vaccine nationalism. And there's been a ton of criticism about this has just become another new extended version with nice language of some suspect practices, right? And again, I don't want to shy away from it. I think we can do better and we ought to do better. And we can only do better if we acknowledge where the challenges are and the problems that we face. I'm going to skip these three and we'll get the slides. This is a quote from Dr. Hirsch, who wrote this in 2021. It's pretty provocative and challenging. Global health institutions are serious about their commitment to working against the legacies of colonialism and fighting racism, then they will need to give up some or all of their power. That means a radical redistribution of funding away from high-income countries, a loss of epistemic and political authority, a limitation to our power to intervene in allied disease. She's, let's say, skeptical, unlikely to happen. So, where do you guys want to go? Let me make it, bring it down to the level of just being a medical student, okay? I spend all my time, Faisal a little bit, worrying about those 20,000 foot, very difficult to answer problems. Our job in this space is to try to create very modest but meaningful opportunities for any one of you to engage in a way that is better than before. Not perfect, to be very clear, right? Not even close to perfect, but better. And our invitation to you, if you want to, is to do it that way. And that means swallowing your pride, having a little humility, being open to the possibility that even if you come from almost no or no privilege, in this setting, as a global health participant, you do have privilege relative to the people that you're about to go intervene on or learn from or study. Does that make sense? So again, I'll share these slides with you guys, but Joe Kolars and a medical student, Joe Kolars is up at Michigan, great guy, published this piece in 2023 in Academic Medicine, and it's meant for you. Personal reflection tool for learners about to engage in global health. So ask yourselves these 10 questions. What are my motivations for this experience? What impact will my presence have? How can I mitigate the disruptive effects of my presence? Does this experience build toward a greater good of sustainability? Am I prepared to approach opportunities with humility? How can I anticipate and respond to ethical dilemmas? How will I bidirectionally communicate with my partners and navigate power dynamics? Are the financial resources required justifiable? School of Medicine puts not a trivial amount of money into making these opportunities available to you. Nothing to laugh about, okay? How will I provide feedback to my host and home institution? How will I reflect on this experience moving forward? He offers 15 pitfalls to avoid. I've seen every single one of these, another dozen. Pre-departure. Pursue experiences without the co-design the place you're going. Dr. Said, I really want to go to Namibia. Why? But I really want to. And I really want to do surgical rotation. Do the Namibians want you to come and do a surgical rotation there? The answer is no, or I don't know. You know what the answer is going to be from me. And I hope you understand why. Right? In country, nothing pisses me off more, and I'm gonna say pisses me off than this. If you can't do it here, what gives you the right to do it there? Think about how insulting it is, how undignified that is for the person receiving. And I say that personally because I've witnessed it. It happens all the time. And it's, if you have any sense of moral compass, you have to stop yourself. Okay? You would never accept that for yourself or your loved one. So what, just because you're somewhere else and nobody's policing you, you get to do that? One time I will be very angry. Give me a break. Don't do that. Okay? Last one is post-trip. This is the one that I see a lot. You've had your trip, you've taken your pictures, you posted it on Instagram. And then when they come calling to ask to stay connected, you're too busy. I'm not denying that you're busy. I'm just saying they've done all the work. You got a plane ticket paid for to go there. You got subsidies to get your housing paid for and food paid for. And they email you and say, hey, can you help me out with something? And you're too busy. We can do better. We ought to do better, right? Just as students, right? Forget the big stuff. Just as students, these little things that you guys, you had your hand up. Oh yeah, sorry, you can't read it, can you? Like an actual clinical example, medical students delivering babies unsupervised, participating in the surgery, doing things with scalpels and needles and suturing that, they would never be allowed to do here. Prescribing medications, making a diagnosis of malaria without having ever seen a diagnosis, a case of malaria. Right? Remember, these places are under-resourced, understaffed, desperate often for any kind of help. So it's a really difficult situation. And a lot of times students and trainees are doing it because they think it's the right thing to do. But you have to take a step back, right? And ideally you are being supervised in a thoughtful way, right? That doesn't put you in a position where you feel like, if I don't do it, something bad. Does that make sense? Okay. That it? We're done? I wish I could show you this video. Yeah, I can. So Paul was one of my mentors. Anybody know who the last cup of coffee? This is actually a dinner. Anybody know who these folks are? I'm not going to tease my South Asian friends. Abe and Rani Bang. Highly recommend you learn about them. This is a way to end a positive note. It's 4 minutes. Yeah. take home for me is, A, idealism matters. Right? If you don't have ideals, it's easy to become pessimistic. You have to go and listen. It takes a really long time. And it's not sexy, and it's not romantic, and it's not glamorous, despite all the things you see. It's hard. With that, I hope you guys will join us as you embark on your first year. So thank you for humoring me.
Sign in, there's a QR code.
Oh, been a pleasure. Take a picture.
Yeah.